Hi, I'm the other Ann, and I work with the HIV program at the Texas Department of State Health Services. And I'm going to spend the next two videos talking with you about our final measures around HIV engagement. So we already talked about incidence and diagnosis, and in this video, I'm going to talk to you about ART and retention and care. Now, as discussed prior, for this measure, of all people living with HIV who know their status, we want 90% to get on ART and achieve retention and care. Before we look at the outcomes, let's remind ourselves of where this data comes from. Like with our prior data, our main source here is going to be our required public health surveillance data, specifically CD4 and viral load tests. Now we're going to supplement that data from our programmatic and insurance sources, and also look for HIV-related medical appointments and ART prescriptions. Now also, to be clear, when we're talking about being on ART, we're talking about an estimated count that's modeled from the Medical Monitoring Project. When we're able to reliably model this data, we'll look at on ART. A commonly used proxy that we will use more regularly, though, will be retention and care. Now, this is a direct measure, it's a HRSA-HAB measure, and it's defined as 2 contacts with the care system at least 3 months apart. So we know that 85% of folks living with HIV know their status, and of those, we know 70% have achieved retention and care. And before we start digging further into those outcomes, let's make sure we know who we're talking about. Now, we already know who the Texas priority populations are, and when we look at people living with HIV who know their status, this is how those populations are distributed. Now, this is going to look different depending on what part of the state you're in, but overall, this is what Texas looks like. Now let's take a look at our outcomes. And one way to help understand what our retention measure means and how to prioritize communities and populations within it is by using the stoplight color coding system that we've developed, because everyone knows how a stoplight works. Green means go for it. These areas are achieving their 90-90 goals, and we want to make sure to maintain those effective activities and look for promising practices. Yellow means caution. Just like at a stoplight, you may roll through that intersection at a yellow light, but first you're going to slow down and check for other cars coming and understand the context. These areas may not be a priority, but we want to slow down and examine further. And finally, red means stop. These areas are the furthest away from achieving our goals, and we definitely want to do a hard stop and understand further what's happening. So let's start with the map of the state. Immediately, we can see that there's no geographic region of the state that has been able to achieve our retention and care goals. We can pop up the Part A cities for a closer look, and we can see that unlike what we saw earlier with diagnosis, there's greater disparities regionally. Houston is the largest region of the state and is further away from achieving our retention goals compared to other regions of the state. So we definitely want to stop and understand what's happening there. Outside of those other metro areas, we can also look at other higher morbidity areas around the state that are also in the red, like El Paso and Beaumont. Now let's start combining these elements, starting with looking at priority populations at the state level over time. Each of these bars represents ranges of retention for our priority populations. For example, in 2016, 77% of white gay and bisexual men had achieved retention and care compared to 66% of Black gay and bisexual men. The longer the bar, the greater the disparities between populations. So let's start with transgender women. As you can see, we have some caveats with this data, including only having 2 years worth of reliable data available. We can't talk about retention among trans women the same way we can talk about the other cisgender populations because they have different denominators due to how we're able to confirm gender identity. What's most relevant here is the flatness across time. We can now look at our other populations, and again, what we see is flatness over time and the same population disparities over time. Now let's just look at those 4 groups with the same denominator, and we can really clearly see these population disparities. Disparities like this over time are not about individual behavior, but tell us instead about our systems. In other words, this data isn't about white gay men trying harder to engage in care. Instead, it tells us that our systems of care don't offer the same opportunities to everyone. And then if we want to see different outcomes, we have to change our systems and how we deliver care and treatment. Now let's keep diving in and let's look at our priority populations within our metro areas. Here are our 5 Part A regions. We can see that Houston and Dallas are significantly larger than our other areas. And we can see that our priority populations look different in each of our cities. So let's keep that in mind as we start walking through our outcomes. First, again, because of our data caveats, let's talk about transgender women separately. Just like with their cisgender counterparts, we can't talk about all trans women the same. The experiences of Latinx and Black trans women are different, and we can see that play out in the data as well, with the same population disparities that we see in our cisgender communities. Now let's look at the rest of our priority populations. And what we'll see here are the same kinds of disparities we saw at the state level over time. With the exception of San Antonio, which is a majority Latinx city, white, gay, and bisexual men have the most opportunities to achieve retention and care, regardless of where they are in the state. And everywhere, Black, gay, and bisexual men have the fewest opportunities. Disparities like this that look the same over time and over vastly different cities, again, tell us this isn't about individual behavior. These are systemic and environmental disparities. And finally, let's look at age. Now, of course, these groups are different sizes, and size does matter here. But the main point I want to focus on is who is in the red and the furthest away from achieving retention. And here we can really clearly see that our systems are not made to serve younger people. And more specifically, we see that our systems are challenging the same populations across all our domains, starting with public awareness and incidence and getting a diagnosis. These are primarily younger communities of color and really specifically young Black and Latinx, gay and bisexual men. And as we move into the future, centering the experiences of these communities as we create new status neutral systems of care will be crucial. Before I go, a big thank you to our DSHS and field surveillance staff and everyone who contributes to our big ball of data. And thank you for your time.